the message we're giving as a trust. The Kirkup report investigating maternity and neonatal deaths in East Sussex has also been published, and recommendations are being taken forward. That will be reported to the Quality Committee, and we're marrying it with the Ockenden report so that we've not got lots and lots of different action plans and things coming out. We're bringing them all together and we'll report that through to the Quality Committee. You'll also may have seen that the CQC has published their State of Care report, and I think it reflects quite accurately the national and local challenges. But they also published a report called Experiences of Being in Hospital for People with a Learning Disability and Autistic People. And it really focuses on that population when they're in the acute hospitals. And I think it's part of our role, and in line with our mission statement, that we are an advocate for people in our systems. And so I've been talking to the local chief executives about that report. NHS England has also published a number of important documents, including a consultation on the governance for trusts, including foundation trusts. Dom's leading our review of this consultation, the implications for us, should it go through, and our response, and the proposed changes will bring, and what proposed changes will be brought to the provider licence in order to make it more up to date. But it also sets out new enforcement powers that can be taken. Locally, as I said last time, the system is hot. Records are showing that nationally, the NHS had the busiest October on record, which was compounded by a higher level of COVID patients in hospital than this time last year. We've worked hard through business continuity to respond to these challenges and continue to see inappropriate out of area placements at 0. So we've sustained that level, which I'm incredibly grateful to all the teams that have been involved in that. You'll hear more about that from John later. We're balancing this with our immediate pressures, such as industrial action, sickness, stress, increased need, waiting lists, and pressures in social care, with the need to transform and ensure we're fit for purpose for the future. So it's very much, as we talk about the short, medium and long-term horizons, we've got our eyes very fixed on the short-term horizon, but we haven't forgotten the medium and long-term horizon. So we're doing the work around, and you'll be hearing a bit more about that in at another stage about how we're planning services for the future and our clinical model for the future. There are a number of other important matters in the CEO brief, which I won't go into. I could go into them one by one, but they're in there and you can read them. Yeah. But I think I want to highlight 2 in particular. One is the annual CQC Community Mental Health Survey. I think it is important to say here, our results were disappointing, and I'm not going to soft soap that in any way. They were not good. We were either average or below average across the board. We were the 3rd lowest in the country, and the survey was based on just under 250 people. But I think it's important that we take notice that each one of those people had a bad experience with our service, or a suboptimal experience with our service, and we need to do something about it. So we're reviewing our approach to service user engagement, moving away from engagement to more co-production and co-development, and really questioning how we involve patients right at every stage of what we're doing and their carers. The results of the report, the actions taken, and the impact of those actions will go to the Quality Committee. The other area I wanted to highlight is our annual Emergency Preparedness, Resilience and Response Course Standards Assessment, which was appended to the report. We were fully compliant on 53 of the 57 standards, and I'd formally like to thank Dom and his team for this excellent outcome. So I know from having been involved in my previous trust, that's no mean feat. And finally, I want to personally thank Mandy, who this is her last board as interim chief nurse, and I'd like to formally thank her from me for all the fantastic work that she's done in the role, and the maintaining her values and her compassion through some very tricky decision making and difficult periods. I wanted to end by formally thanking Mandy. So I'm happy to take any questions.
Gosh. Yes, thank you, Jane. That was quite a lot in there. Anna.
Thanks, and absolutely wholeheartedly agree with that. So from me and all the work that we've done together on Quality Committee, fantastic, Mandy. Thank you so much. Jane, just a very quick question about East Kent. I thought that the NHSE had written to all providers saying, work through the recommendations, bring a report back to the board. So I think you're saying it's been to exec committee, it's coming to quality committee. Personally, having read it, I think Kirkup has done quite a different thing from Ockenden. I think he's talked about culture, he's talked about team working, and he's talked about a really interesting phrase, looking good whilst doing badly.
Mm-hmm.
It's just really a question as to whether, if it comes to quality committee, I feel it's some of that is actually a relevance to us as a board. So just your comment on that, really.
My comment on that. So it's come to the executive committee as a briefing and what are we going to do about it kind of thing, not a we've done it all and it's all finished. So it's sort of like setting it out to start with so that the whole exec team know what it says and what the plan is. My view is that the sort of the deep dive into it and the real scrutiny around the report has to happen at somewhere like a subcommittee of the board, and we need to report through there, and then they report on their assurance to the board. But Peter might think differently, and I'm happy to be corrected, but I think it needs that level of scrutiny below before it comes to board.
Yes, no, I agree. Yeah. We need to take a quality improvement approach. We need to know where we are now, where we're trying to get to, and how we're going to close the gap, don't we? And have that done before it comes to board. Kevin.
Hi, totally different tack, Jane, if that's okay. I want to come to our interface with the integrated care systems and integrated care board. I noticed in your paper something I hadn't read before, which was the governance of winter, which is quite interesting concept.
Sounds like a novel, doesn't it?
It really does. Magical realism, I'd imagine. But I guess the specific question was about the ICS and its attempts to govern winter, while we attempt to deal with immediate pressures, and if there's additionality there in terms of the helpful resources, etc., or if it feels like, well, we're all kind of pulling in different directions, so just trying to muddle through until the spring.
So interesting question, because can I respond to that? Is that all right, Peter?
Yeah.
So I think we can't do it in isolation, responding to winter. We have to do it as a system. And I think, despite my initial balking at having to meet once a week for a winter board, it has actually proved really helpful. And the premise we've set at a chief exec level is we are going to, when we come across day-to-day challenges, we're going to address them exec to exec, or chief exec to might be like CNO to CNO or CMO to CNO, and then raising to the CEOs if necessary, and reporting to the winter board anything that we find is getting sticky, or we need an external view on, or we think is a wider problem. And so the winter board isn't an assurance or a performance kind of thing. It has turned into quite a collegiate kind of, we've got this sticky problem and we really need to think of a system about it, and with the aim of supporting the executive teams to sort things out between them.
Right. So when you pull the lever, there's something connected.
And that we can use our levers as chief executives when we need to, and that we're understanding through the CMO, CNO and COO meeting the shared risks and where the risk balance is across the organisation, because there is a risk that I will say, well, I'm really worried about this, and then University Sussex Hospital is worried about this. Well, unless we see it as a whole system risk, then we're not going to make the right decisions. So that governance is show that we've got a shared risk approach.
That is really heartening to hear. Thanks, Jay.
Thank you very much. That's good. Osman.
All I was going to say, Jane's covered the point about the effectiveness of it. It is also a national mandate, I should just say, Kevin. It wasn't just that our system decided to create a winter board. The letter that came out from Amanda Pritchard was very clear about the governance that is required. And I think all I would say is that I know many colleagues on this call, in particular John and Mandy and Claire, are having to there is a lot of sort of paperwork, I suppose is the word, associated with it, and we have been trying to minimize it, but clearly there is a national process for it and we have to comply with that process.
That's great. And to be clear, I was just checking that it was additional, and we weren't returning to a new public management of the whole thing.
Yeah. And I think we talked before about the fact the whole framing of winter also feels a bit like, well, actually, is there really something distinct called winter when actually the pressure is all year round? But I think there is clearly something useful about as you say, having levers connected to something. Is there anything else for the Chief Executive? Thank you very much, everyone. Can I now move us to the cyclical review of our breakthrough objectives, and that this month we're looking at out of area placements, and I think I'm therefore coming to you, John, if that's correct.
That's right, Chair. Yes.
Thank you very much. Oh, there we are.
And here is a slide set that I will talk you through. So, Chair, I will take you through the slides, and then I'm sure there'll be an opportunity for some questions. So just to recap, ensuring that Sussex residents receive their care locally when clinically appropriate, i.e. moving to zero out of area placements, is and continues to be one of our key breakthrough objectives for this year. And I think that is why I referenced when we heard the patient story, particularly around the grounding nature of that. I think it's really important to remember when we talk about numbers, each number is a patient who is receiving their care some distance away from family care teams, local neighbourhoods. Dorian Solar, thank you very much for doing the slides. So where are we to date? So as Jane has mentioned, I think in the CEO's report already, we are at zero inappropriate out of area placements. However, that does mean that we continue to have 63, I think at lunchtime today, patients who are receiving their care within Sussex, outside of Sussex Partnership Trust beds. And I'm sure we will talk as we go through around how we ensure their continuity of care, the oversight that we have, the quality assurance that we have around the provision, much like was being described by Kim and Alex and John and Sarah earlier. There is a contextual piece to this, and I will describe some of the actions as we go, but I think it's important to say MRD, you've heard me talk about this a lot here. What does that stand for? Medically ready for discharge. So patients who are continuing to receive inpatient hospital care, who could be supported, who are well enough within their treatment plan to receive their care outside of hospital. It's a long-standing challenge for us. It's a long-standing challenge for the wider system. However, you can see here that the numbers have been growing over the last few months, and as it stands today, most days we have between 90 and 100 patients across our older adults, our rehab and our acute adults who could be receiving their care elsewhere. So it runs about 20% of our bed stock, so quite a considerable number. So can you just go back one slide? I think we've just, yeah, there we go. So some of the areas, and again, you will have heard me talk about these before when we've updated on breakthrough objectives. You would have read about them in the IPR. You would have heard them referenced in some of the reports from the board committees. But just some of the actions which we have been taking underway to impact on the position that we have. Jane often describes this as there is no single magic bullet to resolving the out of area placements problem, and that is exactly right. It is a number of clinical and operational actions that cumulatively will impact on the wider position. I've started with the length of stay reduction programme because this is our most significant piece of transformational work around length of stay, and I will rightly come on to that in some more detail. But it is taking the quality improvement methodology that we've all endorsed and trying to apply that to the long-standing challenge. Similarly, with our havens, so as again, part of our urgent care pathway, how are we ensuring that we are giving them every opportunity to do what they were set up to do, to provide people with longitudinal assessment, to support people to return home rather than coming into hospital. Like many other bits of the system, we have been setting up programs of work to work with our patients who are the most high intensity users, so people who return frequently into our urgent care pathway. Sussex Mental Health Line, again, we have gone live with Sussex Mental Health Line as in Press 2 for mental health through the 111 portal from the beginning of this year. Doyen Solar, thanks. Maximising the use of our community rehab provision. And you will, when we were talking about the governance of winter, one of the key aspects that the system is trying to work together is around shared risk. So how do we all take significant steps in the right direction so we share risk and are as flexible as possible across all of our services? And this is one of the areas where we have sought to step into that space to make sure that our rehab beds are being as flexible as possible in terms of their criteria, supporting people who wouldn't otherwise necessarily ordinarily go there, because we do need to support patient flow. We heard from Kim and colleagues around the specialist assessment MDT and how we have supported them to change their focus during business continuity. Discharge to assess, we've talked about here before in terms of our housing developments, and again, how we've worked with our commissioners to be as flexible as possible. And this isn't all about adults. So I do think it's important to ensure that we know that we have younger people in hospitals, in acute hospitals, and again, the opening of the day hospital, the eating disorder day hospital in Hove, will look to impact on that. That's not the exhaustive list. It's just to give you a flavour of some of the things that we're doing. I mentioned the length of stay programme, and you've heard me talk about this before. So just to remind colleagues that back in the summer, we established, with support from the PSC, a specific large-scale quality improvement project for a 3-month period. We then, through the executive committee, took a decision, or in effect agreed a business case to extend that for a further 4 months based on a sort of cost-benefit analysis. The impact being we wanted to scale up and roll out the number of QI interventions that we thought were going to have the greatest impact. And the slide that you see there really just describes what those are and just gives you an example of the timeline of how we're doing that. We have actually extended this project beyond that now. It's going into February. But the highlights, I think, to see are 62% of our inpatient wards, our adult wards, are currently scaling up action-oriented MDTs. 81% of our wards are implementing the work around therapeutic interventions, sorry. So this is very MDT approach. We have medics, psychologists, OTs, therapists, nurses, all involved in these schemes. It's very bottom up, it's very frontline clinician, and it's overseen by a program board that myself and Claire sit on. As part of that length of stay reduction program, we agreed that we would pilot or trial or build the business case for a different clinical model in one of our wards at Langley Green Hospital. We were looking to develop a short stay or assessment ward. The Task and Finish group, which was a clinically led Task and Finish group, has come to the conclusion and taken it through the executive committee that that isn't a model that we would want to proceed with, based on talking to colleagues in South London, Dorset, Camden and Islington and other mental health trusts who have lots of different similar types of model. And the feedback has been, one, simply patient flow will prevent it being as successful as we would want it to be, and two, workforce. The alternative plan that we have agreed is to design a clinical model on the ward itself using our existing structures and staff, and as you can see as it's described there, a structured care pathway for complex cases. So how do we work differently? How do we put in place nice guidance, best practice, and actually roll that out with some very specific interventions? And the slide that you've seen can see here is the things that we wanted to put in place and those which are highest and medium and lowest priority. we think we can see early fruits around length of stay. We know that we continue to have a high number of patients with extended lengths of stay, as in very long lengths of stay. We know that is in part, not in total, but in part related to the medically ready for discharge challenges that I described. And we know that there is still work to be done in that area. However, we do think we are starting to see the green shoots of some reduction in length of stay that we think we can attribute to these schemes. Next steps. I think Jane mentioned this at the top of the meeting, that we, whilst we have got to 0 out of area placements, we obviously want to go further. We obviously want to ensure that more people receive their care within Sussex Partnership Trust beds. There is a clear patient experience quality impact to that before you even consider the financial implication, which will need to form part of our plan for the remainder of this and for the next financial year. But as you can see, as it stands currently, we're slightly ahead of our planned trajectory. Just in terms of next steps, I'm not going to rattle through all of these because again, you can see, but it's more of the action that is already underway. Strengthening our crisis cafe offer, working with our blue light colleagues, our specific redeployment business continuity actions to strengthen our urgent care services, some specific Brighton and Hove action around the configuration of our inpatient wards, all things that we think will have a material difference on patient experience, patient flow, and as a result, out of area placements. Final slide from me, Chair. Jane mentioned it again in the Chief Exec's report around the money that has been allocated from the National Fund for to support hospital discharge of hospitals of all flavour. We have been working closely with our system partners, and there's a paper going this evening to the System Winter Board to agree some of the schemes looking to reduce the number of patients who are currently waiting for onward care in other settings. And what we have got here is, and it's a rapidly changing picture, is the first cut of the schemes that we submitted, which, as you can see, will impact on adults and older adults and local authority colleagues and length of stay. So some proposed schemes that will impact on patient flow. So in summary, a number of things that are underway, all of which we hope to continue the direction of travel that we're going in to reduce the number of out of area placements. As you can see, there is no one single thing. This is a very much a joint collaborative effort between operations and clinical colleagues. And I will pause for questions.
Okay, so thank you very much. So before we go into the 63, we should notice the fact that we've got down to 0 inappropriate out of area placements, and the fact that that is a fantastic achievement and something we've been really wanting to get to. I think I suppose the question for me is around the sustainability of that. Are we confident that that's now the settled position that we can start to go at? The 63, but I'll if I may, John, I'll allow you to pick that question up as we go along. So I've got Jane and Martin and Amanda. Jane.
Thank you. I just wanted to thank you, John, and thank you to your team for all the work that you've been doing around this. I suppose there's one bit that I wanted to add to the presentation, that I know at the board we said we would set a target of reducing per month the number of out of SPFT beds, and the target for just so that you know where we're at with that, it's still in place. Our target for December is 70, and we're down to 63, so we're ahead of target at the moment. But I just thought it's important to put that context in. Yeah,
that's helpful. Thank you. Martin.
Thank you, Peter. I've never liked the film Groundhog Day myself, and I'm delighted that we finally seem to be moving away from the same old about out of area placements. So the purpose of my intervention is A, to congratulate the team and John for his presentation, B, to say how beautifully linked with our story in the previous section of the meeting. So it was great to have some vivid colour behind the presentation and the numbers. But C, because this has been a recurrent theme throughout my time with F&I and the board, I think it warrants almost a brief presentation at subsequent board meetings moving forward, because as John so eloquently put across, it's right at the heart of where we do well and where we do not so well. And we have a chink of light here that I think should expose to the full.
Thank you. Good. Amanda. Oh,
Yep,
sorry.
like others, absolutely add my congratulations to everybody involved. I know this has not been easily attained, but again, like Martin has said, just brilliant to see the movement on this, the impact that it's having, the results of the focus and the energy and the multifaceted approach to it. It's great to see the word zero. And if you could bear with me for a minute, John, if you don't mind, would you just clarify for me, when we say zero inappropriate out of area placements, is my understanding correct that what we mean by that is that where we consider them to be appropriate, it is because we are unable to provide that service ourselves and need to look elsewhere? Because it just sits slightly odd for me, the word inappropriate and out of area placement, really.
Yeah.
And then just a quick question really on, you talked about the inpatient wards that had scaled up their actions, and it's about 62%. Meaning there's 38% that haven't yet scaled up their actions, and I just wondered what, a couple of the headline reasons for that might be.
Thank you, Amanda. Good questions. Dan.
Thanks, Chair. Very briefly, just to underline what John has said, both the challenge and the solution are multifaceted, and they require sustained and collective attention, as well as being dependent on robust clinical involvement and leadership. And I think it's the third item in particular that it feels where we've made some good progress in the most recent quarter, not least due to the medical forum that Claire's established as CMO and our new clinical executive that met for the first time last week. So I just wanted to underline those points.
Thank you. Yes, because there's something for me about meeting the target and missing the point, the potential to meet the target and miss the point. And we just need some assurance that we have got the quality still being assessed as we go along, and we're not just reducing the headline figure. And maybe we could pick that up in a minute. I've got Usman next, please.
Yeah, I just wanted to highlight, I suppose, the sort of what we can achieve when we come round things in a sort of targeted and focused way. And I suppose it's worth for the board just bearing that in mind as we go through maybe the rest of the day and the next few sessions when we think about the things that we're going to have to do next year, and about, I suppose, making sure that we're taking the same approach and learning from how we've got this done into some of the future work. Because I think for me, it was, I haven't been here as long as Martin, but it's definitely been something that's been talked about, and actually it's been really good to see the work. And to the point about how we do it, as opposed, get the target but miss the point, I think it's been really gratifying to see how much clinical leadership has been involved in this and the sort of work behind it. And of course, because I'm the FD, I will say there's also other benefits from this, but actually those benefits have been really secondary. The main driving thing behind this has been it's not appropriate for patients to not be in those kind of settings. And actually the focus on that has a byproduct of improving the finances, but it's very much that way around. And I think we should think about that as well as we go into next year. If we do the right thing and we do it in the right way, chances are we'll get everything else right as well. So I think there's just some important things there for us to keep in mind as we sort of have the conversations later on today and in future sessions.
I think that's really important, Usman, because I think we've always said that this is about quality. This is about getting the right care in the right place. It's about quality, and then other things then fall into place. But we do want to keep quality first. John, I'm conscious there's a risk that I just increase the number of questions that you've got to respond to. Do you want to come in now and then I'll go back out again, or are you happy to?
I'm jotting them down, Chair. So
okay.
Why don't we finish the questions and I'll try and wrap it all up.
Yeah. Okay. I look forward to that. Mandy.
Thanks, Chair. It wasn't a question, it was more of a
Oh,
comment
no, of course. Yeah.
about the quality improvement aspects of the different initiatives and how the solutions really do lie with the workforce. So all of those work streams that John talked to were multidisciplinary and had that clinical oversight, but just the value of those, like the length of stay, the quality improvement process around it. We know that staff have the solutions who work in the services, so that's really good to see that come through. And similarly, in places like Langley Green, we've had a recent presentation at the CQC engagement event where actually the quality improvement change ideas and drivers really did lead to results. So I just wanted to note that.
Yeah, thank you. I think that's really helpful, and as a way of giving that that assurance. I've got Kevin and Joe, so I'll go to Kevin.
Hi all. Yeah, well, yeah, agree with others. This has been, this looks like, and from what I've read, is a really comprehensive, broad-based piece of work. I love the emphasis on kind of bottom up as well as top down, and that these are solutions being arrived at by staff teams. And yeah, it looks like it's got legs. It's great. Of course, I'm going to ask the other question, which is, you know, and I remember vaguely kind of the impact analysis you did on this and some of the risks you flagged up. So wondering if there have been unintendeds and if they're major, and I suppose in particular, you know, has it had an effect on the definition of inappropriate as well? So just, yeah, the kind of approach to unintended consequences, where those system pressures have gone and how we've absorbed them, if you like.
That's really helpful. Thanks, Kevin. Joe.
Yeah, thank you, Chair, and thanks, John. It's really quite heartening to see that we've actually achieved such a significant shift here. But I want to pick up on the 20% who are occupying beds and referring to the medically ready for discharge. On one of the service visits that I made recently, the matron was very concerned that actually one of the things, and maybe Claire, you'll want to come in on this as well, that he was particularly exercised by the fact that quite often there are people who are medically ready to be discharged, but there is a problem both in terms of availability of doctors to actually sign off. So you're left with the nursing team unable to make a decision, particularly on a Friday, but equally the link between not just the availability of places to transfer people, but also how are we working with the local authority and the community services to begin to really address this problem. And I think, you know, again, I sense that it's not going to be a quick answer, and it's going to take more than one action. But I think 20%, if you translate that into hard cash, is a significant number. So I'd be quite interested in hearing a bit more about what is happening there and how we intend to tackle it.
Okay,
Thanks.
I think that's helpful, and it's good to hear that coming from a service visit, Joe. John and Claire, how do you want to? Shall I go to Claire first, John, and then come to you? Yeah, Claire.
Thank you. Yes, I mean, I can, I guess in terms of discharging, my thought would be that there should always be Monday to Friday medical cover that is able to discharge on every ward in every unit. And if there isn't, then I need to know how that isn't happening, because you know, ideally we should be planning for discharges 7 days a week, and where we're able to support people to go home, for example, with family who are more available at weekends, that should be what happens. And certainly Fridays shouldn't be an issue. I know sometimes there are issues with placements not wanting to take patients on Fridays, care services not wanting to start care packages on Fridays, because they're just about to start, and then the weekend will come and they have less senior cover at weekends. And that is quite a common thing across the country, not just with Sussex, that there is that still senior cover is more Monday to Friday, not just in hospital, but in the community, and not just our services, but social care as well. I mean, I think what you've highlighted, Joe, and I'm sure John will speak more to around the medically ready for discharge is, yes, this is a huge problem, and it's a problem for us and with our acute colleagues as well, and something that we are unified in our conversations that we're having weekly across the whole system about how do we, as healthcare, get into that space that is the social care support post-discharge to ensure that our patients are safe and able to leave hospital as soon as possible. But absolutely, there is a delay. I don't know if John, if you want to.
Thanks, Claire. Yeah.
I'm happy to come back, Chair. And apologies if I've forgotten any. I'm sure colleagues will flag. So
I've got a list.
Let's hope they match. Start with Amanda's question, because that, I think, probably helps frame it in terms of the difference between inappropriate and appropriate. So how we describe inappropriate for us, Amanda, is patients receiving their care outside of Sussex. So we were previously supporting a number of patients to receive their inpatient care in Norfolk, but there was a hospital there that often had capacity and that we developed a relationship with. Appropriate out of area placements for people receiving their care in the independent sector in Sussex within the beds that we have block contracted. Does that make sense? There's so many different definitions of.
Yes, I think it's good to know the one we're using. So thank you.
Can I just add that we're talking about acute admissions there, John? Because I think it's important that that is not spot purchase placements and sort of tertiary care, quaternary, tier 4 placements. This is acute beds like we have across Sussex.
Yeah, completely agree. And Claire's right to rate the definition, because the patient story that we were discussing earlier was receiving her care in what we call, in effect, a specialist placement, Amanda. So not an acute adult psychiatric placement. It's confusing to all of us. Why were some wards not haven't yet had their projects scaled up? I think was one of the questions. A couple of reasons, really. One is simply the timing of when the slides were written, and secondly is we've been trying to go at the wards that have the greatest challenges first, in terms of, we know there's lots of unwarranted variation, so it's really about where it is in the programme. To Peter's question about sustainability, because I think that's probably the most significant one. And I think it talks to the longer term implications. So I think there's two bits for me. So one is around the model of care. If we are going to sustain this and make further improvements, I think it has to be about a different model of out of hospital care. We talk about community transformation a lot, and that's not just something that's within our gift, but it's about a different model of out of hospital care. And I think it's possibly also about different risk thresholds. There is a finite amount of inpatient care available from just an availability and a financial perspective. And simply, we know that it's not necessarily the best thing for all patients to receive their care internally. There is only so much, I think, that we can achieve in this space regarding process. So the management of length of stay, the management of medically ready for discharges, the gatekeeping of admissions, all that sort of language that talks of process can only, I think, get us so far. I think it's important to stress that we are still in a post-COVID environment. And for those of you who've been around a while, we'll know that we have struggled in this area for a long time. That's been alluded to. But it has gone up and down, but it has never gone as high as it has since post-COVID. And it is a very different landscape to the one we were in previously, not least the financial and political position of the wider public services, all of which impact on that. And the second, I think, in terms of the sustainability, is around length of stay. We benchmark okay regarding length of stay as an organisation. We know we are some outliers in some areas, particularly for the longer lengths of stay, but as a whole, we benchmark okay. We've said before and modelled before and discussed in many occasions, if we were to take 1, 2, 3, 4, 5% off our longest length of stay challenges, that would have a really considerable impact on the available beds that we have. However, we know that we have had those number of people spending that amount of time in inpatient care for a number of years. The reason I stress that is it is just, I think we're all important that we're all cited on the real scale. To make a shift on that dial is really quite a considerable ask. When you look at the national benchmarking picture, the most significant amount of occupancy of psychiatric bed days is for patients with extended length of stay. We're not unusual in that respect. So to move the dial on that is going to require really something quite different. To Joe's question around medically ready for discharge and accommodation, Joe, I think you said, what does 20% equate to in financial terms? I haven't got that answer off the top of my head, but what I can tell you is today it's about 7,000 occupied bed days. So if you did the maths in terms of, you know, your average length of stay in an adult ward, maybe 40 days, you can immediately see the impact of that. How are we working with our local authorities and community services to address the problem? The matron that you spoke to is absolutely right. It's not just about the bricks and mortar solution. It's about the bricks and mortar solution that can provide and specific support and support people with complex needs that they weren't necessarily or haven't necessarily been used to doing so. I haven't got time to do it justice here, but the auspices of the mental health accommodation strategy that we agreed a couple of years ago, and now the mental health place-based accommodation plans do describe the development of specialist rehab units, crisis houses, discharge to assess provision, etc., etc. There are risks in that. There are delivery risks in that around capacity and resource, and we've seen some of those challenges within our West Sussex and Brighton and Hove systems over recent months. But there are detailed plans around that. But as you rightly said, it's a longer term. It's a longer term objective. I think the changing relationship that we have with our local authorities through the ICS and with our community and voluntary sector will talk to that. Getting us stepping into that space is, I think, where we need to be.
Okay.
I hope I haven't missed anything, Peter. I think I've covered it.
No, I think you've certainly covered all the points and issues that were raised. And between you and Claire, I think you've certainly helped us to understand where some of the risks still sit, and also the challenges in terms of the sustainability. I mean, I suppose there is a conversation to be had at some point about with longer length. So there's two bits, isn't there, as I understand it, John? There's the vacancy rates in the community, particularly in the crisis teams, that would help us, and that's somewhere where we need to shift. And the other bit is around the longer length of stay, and actually how much can we start to exercise more influence over what's available in the community for people to move on to. And I think one of those is probably a bigger conversation than we can manage now. But I would just quite like to know where we are with the crisis teams and the vacancy rates, because it seemed to me that was quite a key indicator of our ability to move people on as well. And it was something that I know we were trying to shift the dial on.
I'm happy to. Oh.
Okay, I don't mind who. Yeah, I just felt it was one of the things that we said was significant.
I was going to say Esmond. I'll start, and Esmond can come in if he wishes to. So, key objective through our business continuity and incident management team approach. So, what we've agreed, Chair, is that we would seek to increase the capacity within our crisis team. Well, seek to increase the clinical capacity within our crisis teams to support a number of additional facilitated or, as we might describe, early or supported discharges from hospital. How would we do that? We think that the best way to do that is to increase capacity within our crisis teams, within our community teams, our assessment and treatment services, so we can support flow. So the patients that are receiving a lower level of intensive care from crisis teams could step down into community teams earlier. That is the sense, or that is the plan to it. We are taking a redeployment approach to that, a threefold redeployment approach. One, asking people simply if they want to do more shifts and come and work on the bank. Two, some very detailed work with everybody in the organisation who has a clinical background in a non-clinical role, and supporting them to have conversations with their professional leads to identify what amount of time that they can free up. And our psychology leads and our therapy leads have been very proactive in that space. And thirdly is a more detailed, carefully nuanced bespoke offer from our primary care services, thinking about what they could perhaps offer on a more wholesale basis. However, we recognize that that will come with some element of risk, and we need to be absolutely assured that the impact of that does not is not an unintended consequence, as you've described. And actually, that was one I didn't come back into. So perhaps I'll just cover unintended consequences. Because Kevin asked the question about reducing bout of area placements. Are there any unintended consequences in terms of risk? It's something we've talked a lot about, and it's certainly something we've talked a lot about with our system partners, because inadvertently, are we creating any further risk on us or them? At this point in time, we don't think that the numbers would suggest that we are, but we do keep a very careful eye on two metrics. One is the number of people waiting to come into hospital, and two, the length of time they are waiting to come into hospital. So at this point, we're saying, I don't think we're saying it is, but we are very cautious of it. However, we do recognize that our clinical teams already, even before we reduce the number of out-of-area placements, do hold a considerable level of risk within the community. There are a number of patients in the community waiting to be admitted who are liable to be detained. So it is not to say there is no risk. There is considerable risk, but I don't think we can evidence at this point that it has increased. I'll pause for breath. I hope I answered those two bits, Chair. And Usman may wish to come back in on the redeployment piece.
Usman, do you want to do that?
Well, I think John's done a great job covering off the conversations we've been having through the ICC process. I think it's worth just saying, I mean, in the finance report, you'll see we've set out in quite a lot of detail the vacancy rates at team level within crisis. And I think it's important to know that what we're doing right now is the sort of short-term measures in order to enhance capacity by doing other things like redeploying staff. The longer-term solution to this has got to be about recruitment, and how do we, what set off incentives or changes we're going to need to make as we go into next year. And again, I suppose I will stop doing this, Chair, just thinking about the conversations about next year and where we need to prioritize and focus. I think, recruitment broadly has always been an absolute priority for all NHS organisations. I think for us, there's something about how do we get into actually really targeting and saying these particular teams are where we're going to focus. And that's the conversations we've been having internally with Claire, with her team around what do we need to do to gear up in order to make sure that that's where our focus can be for next year.
Yeah, no, that's I think that's really, really important. Mandy, I'll come to you and then I'll do a sum up.
Yes, just to say thanks, Chair. We are keeping a really close eye on the level of serious incidents and patient safety incidents alongside this piece of work. So I think that's really key to some of the aspects too. And during business continuity, we are stepping up the quality and safety visits. So the governance and quality and safety aspects are very tight. So I think that's important to know.
Yeah, that's really, really helpful. John, thank you for the presentation. I think it was a really clear presentation. Obviously, I mean, the board wants to pass on its thanks and its congratulations to everyone who's been involved in getting us to zero on the inappropriate placements. I think that shouldn't be underestimated in terms of the achievement there. I think that we're really pleased to see that you're still trying to work on the 20% month-on-month reduction and that we're ahead of target at the moment. I think that it's really good to hear the conversation about making sure we don't just meet the target and then potentially miss the points, that we're keeping this as a quality improvement exercise, and to hear that the clinical colleagues are engaged in the process and ensuring that there is that we are being led by quality in order to reduce that, and also that we're keeping the use of the language appropriate, inappropriate, constantly under review, so that we don't unintentionally normalize something that we don't really want to normalize. Yes, the language needs to be helping us at each point and is from a patient and quality perspective. Clearly, I think you've been very clear about what what are the risks to the long-term sustainability of the position, and I think they're well rehearsed within this board in terms of vacancy rates in key teams, but also actually how can we shift people appropriately and in a supportive way who are medically fit to discharge. And there's clearly something both about the capacity within our own organisation and the skills and competence and capacity within community organisations that we need to continue to work on to make sure that we can do that and we take some control of the wider system in which we work. But a really good place to hit at this point in the year, and clearly then very much informs the breakthrough objectives for next year, and good to see that actually there's a forward trajectory and forward progress. Have I missed anything? No, that's the right answer. Thank you very much indeed. John, thank you, and please do pass on our thanks to everyone else who was involved both in presenting and in the wider work. So can I now move to the integrated performance report, please? Who's going to kick off?
Right.
Yes.
I will. So bear with me, Chair. Sorry, I'm just opening up the right file in the background. So
I think you can assume that we've read it.
I'll assume that it's been read. I will start off, take us through sort of some of the key points, especially in the context that we have changed it. And then I'll go to John for some of the sort of operational service level specific details. So you will, I hope, note that we have, building on the conversations that we've been having, started to change how we sort of do the reporting of the integrated performance report. You will see that there is an appendix in the main pack that sort of has the standard dashboard style list of KPIs. It's got the SPC charts broken down by each of those core relevant areas that shows it. So all of that is still there, and hopefully if people have questions on it, I'm happy to take them. What we have done though as well is now implement, and hopefully you'll all see the performance report focused around some of the specific KPIs and trying to just help the board and focus our attention on those areas where we think we should be focused. And sort of where the data lends itself to saying this is where we should spend the majority of our time. I think it's fair to say, and I don't think this is a secret, that of the 30 core standards that we have, we are not achieving against all of them. And while it's really good that on the 7 that we are sort of really clearly achieving, the majority are of those on the national, against the national standards. So the majority of the national standards we are delivering. And I think that is an important point. I think it's also important to note that we're delivering or close to delivering against many of the quality standards. So hopefully I think the way we've set that out gives people some assurance. But equally, this way we've now highlighted this, I think it also draws attention to the fact that there are a number of, in particular, local indicators where we are not on plan. And I think that's where we sort of will start to put what have been putting our focus, but hopefully can, as we move into next year and think about how we sort of develop this going into 23-24, that'll be the focus. The things, I suppose, just to, in addition to that, specifically highlight as well, I think it's just important to say, while we could be thinking about every one of those 30 KPIs and that they are all important, one of the things that we've been doing as an organization over the last few months is saying, in the context of the constraints that we operate, both in terms of operational levels of activity and the workforce challenges that we have, it's difficult to think that we can make significant improvements against every single one of those 30 indicators. And therefore, what we've been doing is sort of prioritizing, how do we keep patient safe? How do we make sure our quality is at the right level? And therefore, in the context of that, what do we need to prioritize in terms of KPIs? And I think hopefully that approach has started to generate some improvements. In particular, 2 of those areas were around out-of-area placements and inappropriate out-of-area placements. And we've just had a discussion about that improvement and how the focusing in on the particular KPIs hopefully will take us into a better place as we go into next year. And while that's the good news, I should also say we have also highlighted within the exec summary and within the main deck there has been a deterioration, and a relatively significant deterioration in our complaints response rate. And I think we've been transparent about that. That sort of now sits in a sort of, a lot of work is happening around it. And I'll sort of come to Dan once we come to the relevant section within the IPR if he wants to talk about it any further, given that that's now moved to the Communications and Engagement Directorate. In terms of the benchmarking, you'll hopefully all start to see that this is now becoming a theme, that we are going to start producing more and more benchmarks, and we'll start to increase the number as we get them. We started originally when we were looking at this at about 4. We've now increased to over about a dozen, and I think over the next couple of months, as we are clearer about data sources, both internally and the work we've done with Gurpreet's team around our own DQ and our own strategy, and working with regional colleagues to get access to national data, start to develop this. But again, I think it hopefully gives some context to our own performance. And while I think we absolutely would recognise there are areas to improve on, actually, compared to the sort of comparator position across the country, I think we're in a relatively decent position, I will say. I'm careful how I say that, because it's not, I don't want to normalise our performance position. But I think it's to recognise where we are against the comparators. There are a couple of specific areas, CYP ED and CYP ED routine and urgent, where we have got some well-known DQ issues which we've previously discussed. When we come onto those areas, we can pick them up specifically, but our local performance, I think, is significantly more in line with the comparator position, if not the national target position. I will stop talking at that point. Hopefully that gives everyone a sort of clear summary of where we are, and I'm happy to take questions on those bits when we come to it. And then what I'm going to do is go through the core standards that we've rated, sort of where we require action. I think it's worth saying that we've been having internal discussions as an exec team, and when it came to the exec team last week, around some of the items that are currently listed in the amber section, so monitoring. And I think there's been a view that probably a couple of those, and John can talk about those in a bit more detail, around risk assessments and care plans, about is amber really the right place for them, and given their importance. So that's the sort of, this isn't a, we've done it and it sits in a category, it's a live document. We look at it, we discuss it every month, and then say, well, depending on the importance of those issues, the impact that they could have, do we need to move those focuses and sit now in a different section? So hopefully you'll see that iterative process as we go through this. I'm going to suggest we won't talk about out-of-area replacements, given the conversations we've just had. And then before I go to John, actually, it might be worth if I just go to Dan. I apologise, Dan, to talk about the complaints response rate first, and then we'll go to John to talk through a couple of the other points around routine assessments. So, Dan.
Thanks, Osman. And on complaints, what I would want to do is assure the board that we're not in the least bit complacent about response times and breaches, because timely responses are a fundamental part of treating people with respect. It's clear we're not where we need to be right now, and the decline in performance has happened on my watch as exec lead. At the same time, what I would want to do as well is underscore the point about the quality of the responses we provide to patients, carers and families in terms of content, clarity and tone, because to my mind, quality and timeliness are different sides of the same coin. We need to get both right, and both are subject to significant focus right now, which is the main point I want to provide assurance to the board on.
Good, thank you. I think that's helpful to know. And then Osman, you wanted to go to John, is that right?
Yes, if that's all right, Chair. John's just going to pick up a couple of the other red-rated KPIs around assessment.
Thanks very much, Usman. I think it's Usman touched on it, but it's worth just rehearsing. So if you are alarmed when you look at the CYP ED benchmarking data, that is because it's a 12-month rolling average. We know, because we've looked at this continually and it's in the pack, that our performance is and has got to a position where it is considerably better than that. However, we know, because we spent some time looking at it in our exec committee this morning, that is something that is always requires attention and is very susceptible, particularly to workforce challenges. Risk assessments and care plans, again, just to push slightly on what Usman described, you will see that it is in the monitoring section. Collectively as an exec team, we will be moving that to the high section, i.e. the requires action, because of the patient safety issues behind it. It is positive to see that our performance is steady. However, without putting words into her mouth, Jane would rightly say that means there are more than 10% for care plans of people who, it is not they do not have a care plan, it is they do not have an up-to-date care plan that has been reviewed within the last 6 months. So we want to move that to the requires action. It's really just to touch on two things, really. Waiting times, I wanted to just mention, again, we've talked a lot about waiting times. We know that through our breakthrough objectives that waiting times, our focus has been on reducing 52-week waits. And when you look at our breakthrough objective, we have seen a reduction. Some of that has been around the data quality issues. However, we know that we have also made some steps in reducing the numbers of people, particularly within our adults and adult eating disorder services, waiting longer than 52-week waits. Through all the work that colleagues in Usman's and Gurpreet's teams have done, we know that the driver of our waiting times position is around our neurodevelopmental waiting times, both in adults and children's. You can see that played out in the data. We know that particularly in children's services, that the demand is outstripping the capacity that we have received through long-term plan investments, and that presents us with our greatest challenge. For next year, both the remainder of this financial year and next financial year, we want to move the focus away from the process and the data around waiting times, which is extremely important, and very good work has been done within the waiting times program, to a detailed understanding of our demand and capacity piece at team level, but also working with our clinical teams for them to think as creatively as possible around the waiting times initiatives that they can put in place. Seeing people sooner, seeing people in a different way, different offers, digital offers, weekend working. It sounds obvious, but as we all know, that mental health services aren't as close to that agenda as acute services have been for a period of time. It is worth noting, I think, for Hampshire CAMHS, the action that is documented in the pack around the reduction of 52-week waits that they made, and to just allay anxiety, because it suggests a very considerable increase in assessment activity, bringing the 52-week waits down, but that assessment activity has reduced. That is deliberate, because they wanted to impact on that in that way, but they're also having to pay attention to the balance between assessment and treatment. And that is one of the ongoing tensions. I've mentioned neurodevelopmental services. We know that we have a system-wide program of work, which we now have a strategic system-wide group, which is overseen and chaired by the ICS Chief Medical Officer. There's a very considerable program of work as now one of the ICS mental health work streams, and we're expecting to see the first cut of an investment business case by the end of this calendar year. However, recognizing that next year is likely to be a challenged financial position, and our collective system-wide ability to invest in that might be limited. We will touch on finances, we will touch on staffing considerably when we talk about finances, but I think it is important to recognize the level of work that's going on within the temporary staffing reduction space, and we are still continuing to see a shift from off framework to framework agency. It doesn't resolve the issue, but it is direction of travel in the right way. I will pause, Chair. Happy to take questions, as I'm sure Usman and others are as well, on any of the specifics, but those are just some of the highlights I wanted to draw out.
No, that's really helpful. Anna and then Kevin. Anna.
Thank you both, and thank you for these reports. And I think, we're getting more and more kind of clarity, I think, coming to the board. So really grateful for that. I suppose I've got a couple of questions. One is just a comment on what Dan said. I'm really pleased that complaints analysis is coming to Quality Committee. I think we want a lot more detail there on how the kind of changed approach is having impact. So I'm guess that'll come back again to the board, but we're kind of welcoming that to Quality Committee. The second was I just wanted to understand, because I feel as though the IAPT issue has come to us at Quality Committee. The issue about the digital solution, which seems to be getting in the way. I just wonder whether that had been solved. That was my first question. Then the second was about waiting times. You talk about the interim measure there, the kind of changing the way we're measuring waiting times. And my question is that shifting the goalposts, or is that actually addressing the kind of fundamentals here?
I'm happy to. Do you want to, Chair? Would you like me to take Kevin's question as well, and then try and come back to both of them?
I would take Anna's, I think.
Okay.
Thank you.
So I will defer to colleagues on the first question about the complaints. In terms of the waiting time standards, I suppose I should have picked that up specifically to say we have, just for completeness, put some information around the new standards that are coming. I don't think it's a change just to reflect the difficulty. I think it's actually a good thing, but it will make difficult reading, because what it will do is say it's no longer about how long did you wait for an assessment. It's about saying how long have you waited for treatment. And I think that is, I suspect we won't be the only trust in the country where that is a challenge. But it is a good thing, because I think it draws light and hopefully will then focus our attention, and not just our attention, because I think it's fair to say our clinicians talk about it every day. And I know Claire's team, the clinical exec, have been talking about this real challenge around how do you get the balance between capacity to do the assessments, or great, having done the assessments, how do we then make sure we have the capacity to do the treatments? And I think this will draw that out and hopefully allow us to have different kind of conversation with some of our external partners around potentially the resources and the way we will have to work to do that. So I think it's a really good thing. It will take, I think, 6 months to really, there's quite a big program internally we'll have to go through to be ready to do that, along with other organizations. But I do think it's a good thing. And it's not a sort of an attempt to say, oh, this has been really difficult and performance is deteriorating, let's change the goalposts. I don't think it's that.
Thank you, Usman. Anna, did that help? Okay. Kevin.
Hi all. I've got a few questions. Shall I just rattle them off? Is that helpful? And then I'll get to it. Yeah. So the most pressing question. I was heartened to hear that our approach to care plans and risk assessments is likely to move to action. I think I would like to emphasize, that in my experience, and what I've read, the CQC are on this, coroners are on this, but most importantly, it's on the underpinning actions on our suicide reduction plan, right? So absolutely would endorse that. But I guess the question for me is, what kind of risk do we know? What kind of risk we're carrying, particularly within the community around service user care, and if we've got some missing bits, how does that affect our assessment of risk? It might feel like I'm on a bit of a risk I'm pogrom today, but that's what's cropped up for me. A couple of other hopefully fairly quick questions, kind of clarity questions really. One observation about the neurodevelopmental waiting list section. It struck me that it's at a very, so the actions are at a very immature stage for that. A lot of the actions are about how we're going to get the actions together. So I guess clarity about what we're going to do about that. And on the waiting times, a little bit of assurance for that, but the data cleansing exercises that we went through, there was a couple of lines saying they were safe, but are we sure that the data cleansing was safe and that people who were removed from the lists, should have been? And one last thing which popped up for me was about intra-trust waiting times. We hadn't really appreciated before that there were waiting times as people moved from various interventions within the trust, and I guess how that is handled. There's a lot of questions, I know.
Okay, well, let's do them. I think we'll do them in reverse order. So I think there's something around actually just the definition of intra-trust and how that's handled. Then there's something about the data cleansing. Then there's something about actually, are we getting to the level of maturity around the neurodiversity waiting times that we wanted to? If we could deal with those. And then I think there's a bigger question, as I understand it, Kevin, about the fact we use this phrase that we're carrying a lot of community-based risk.
Yes.
And it's just making sure that we understand that and what the actions might be to address that. I've got some hands up. Are they to respond to these questions, or are they to make other points? John, please, then do come in.
Maybe I nodded first, Chair. I will try those, and others will come in as well. In terms of intra-trust referrals, Kevin, that you've described. So one tenet of the waiting times programme is looking at inter-trust referrals as the way that you've described. So we are currently reporting those as people who have been waiting for longer than 52 weeks. We don't think that they are people who are waiting longer than 52 weeks, but it talks to your other point as well around the safety. How can we be assured before we wholesale start closing referrals? So to give you an example, one of the actions that we've taken that you'll see described in the paper is around the closing down of obsolete teams within the primary care setting. We have done a very significant process of clinical audit of all those cases to ensure that that is a safe thing to do. That has been taken through the waiting times programme and taken through the clinical governance of that particular CDS. And we would be and are doing similar approaches for the intra-trust referral piece. So it is not just a remote digital process. There is a clinical assurance oversight of that. I'm just going to keep going, Chair, and then others can come in. Neurodevelopmental waiting times. It's a fair push, Kevin. Thank you for raising it. There's lots going on in that space, and I think we probably almost limited by the space in the report to be able to describe it. So there has been, so some of it is simply just actually a genuine understanding of what it is that our capacity is, what capacity do we think we need. There are, just to give you a flavour, so we have done a piece of detailed clinical validation work to understand if actually the best course of action is to bring in an external organisation to do wholesale clinical validation. The team have worked up a series of initiatives that they would want to put in place as there's the resource to do it. There is detailed pathway mapping groups that are not just internal to us, they are provider wide, because other providers provide bits of the pathway, and we recognise that the transformation simply cannot sit with us alone. There are discussions around shared care protocols around ADHD prescribing between ourselves and primary care and the development of LCSs. So there is a considerable number of actions behind the scene that I think we probably do with providing you with some more detail on in the future, because it is such an area of concern.
Or a quality committee, yeah.
Yeah, or through quality committee. And to your last point about community risk and how assured are we around our community risk? So we, of course, we have a number of access routes, and there are rapid access routes, there are urgent care access routes. So the majority, if not all, of the people that we've got sitting on our waiting times are people who are classified as routine referrals. However, within individual services, there are obviously clinical stratification processes. So if I think about our eating disorder services, very, very clear clinical stratification around a red, amber, green that would be described along physical healthcare issues, morbidities, etc., etc. The same in our neurodevelopmental waiting lists. Saying that, we know that we do carry there is a significant level of risk. However, I think we can be confident and say we are aware of it, and it is clinically assessed. But it is ever changing. The neurodevelopmental piece is a good example. We've recently experienced, because of pressures on primary care, a change in clinical risk with primary care making decisions around whether they will continue to provide treatment and titrate patients onto medication, and then that might fall back to us. So it is a fluctuating piece, but I think individual services do have processes of risk stratification that can evidence in what you're describing.
Okay, thank you, John. Jane, do you want to add to that or complement that?
If that's all right. So, Kevin, the neurodevelopmental weights is a really interesting one, because, as I'm sure you're aware, it's not just us in the system that treats people with neurodevelopmental problems or assesses them.
Absolutely.
And so myself and Mike Jennings, the Chief Executive of Sussex Community Trust, asked to meet with Dinesh, the Chief Medical Officer at the ICB, who is leading this piece of work, and offered our support to him to think about how we look at it as a system. There's also ESHT provides a service as well, and we want to see the risks as a whole, but also the actions as a whole and across the lifespan, rather than in lots of silos that are around at the moment. So as a chief execs group, we've committed to look at this differently together and not be protectionist about our own organisational boundaries, and think about how we can work together to make this better for the people in Sussex.
Thank you. That's really helpful. Joe.
Come on. Thank you. So, simple question, John and others. So, since the work began on the waiting list management, what has been different? What's been the impact for people on the waiting list? How many people have been treated? How many people have been spoken to and contacted?
Joe, I can't give you a specific answer now to say how many people have been spoken to or contacted, but I wonder if your question is how many more people have been spoken to or contacted than otherwise would have been.
That's not my question. My question is, so what? What difference has it made that so much effort has been put in to this area, which is really important? Because if you remember going back a few months when you and I were discussing this, the initial problem was about identifying who's on the waiting list, should they be on the waiting list, and so on. And a lot of effort and work has gone into trying to clean up the data and have a realistic appraisal of the concerns of those who are on the waiting list. But what I'm not hearing is what impact is it having on those people who are on that waiting list? How many people are actually being treated? What's happening to those people? Because, sorry, to me, I'm hearing a lot more about the process rather than the impact.
Yeah. No, it's a fair question, Joe.
It's nothing like a question that then ends up with 4 hands going up, and I don't know where I'm meant to go. I don't know where I'm meant to go next. So Jane, you decide how you want to handle that.
So I think because we've done a review into people on the waiting list and to quality assure, probably Claire and Mandy to speak to that, if that's all right.
Yeah.
Okay.
Yeah, no, I'm happy to come in. So in terms of the waiting list management, there have been, so people are contacted, and I guess the so what is, depending on what happens as a result of that contact, they are reprioritized. Similar to John, I can't tell you how that happens, because I think it is what the team does within that time, within their normal working, that they will then reprioritize and see people sooner where they find that somebody is struggling or their clinical needs have increased, and actually where they were sitting on the waiting list, they need to be bumped up. And certainly from talking with our adult eating disorders services, they are doing active waiting list management in this way. And I guess the so what is, there is a lot more flexibility in where they prioritize people who are seen. It isn't creating capacity to see more people, but it is allowing them to have contact and ensure that people, while they are waiting, are safe, and that they are seeing the right people as soon as they need to be seen.
So are you saying we have no idea how many people have been treated and taken off the waiting list?
No. I'm saying that what I can't tell you is how many of those long waiters or people who had a potential long wait have been reprioritized and seen more quickly. But they do know and are monitoring, as the teams do this, who they are seeing and how many people they are seeing. Sorry.
John can talk to the numbers more. John.
I can, yeah. So I don't know the exact figure off the top of my head, but we know through the weekly waiting times oversight groups that we have, which are held between the performance teams and every individual clinical team, that we have taken several hundred people off the back of the list. That is not just data quality issues. We have resolved people's clinical outcomes. And I know in previous reports we have actually put in the figure, because I remember it was about 350, yes. I think 2 boards ago. So we do know that we have I think it is fair for us to say we have seen more people when we have resolved care for those people. There are a couple of slides in the back of your pack behind the national waiting times piece that describe the shift in activity between internal referrals and external referrals, and there's some waterfall charts to show you those,
Right.
which does give you an idea of the shifts in activity. Yes, there are increases predominantly within the neurodevelopmental piece, and there are some internal changes to team categories, but that the numbers net off. We also know that the other area where we have seen, because there are specific objectives related to it, is around a backlog reduction within adult eating disorders, where there is a specific waiting time objective, which is a result of increasing the capacity for increasing the capacity from psychology assessments doing work with people with less acute eating disorders. So, Joe, I don't have the figure just here, but we can evidence that we have increased capacity in some areas and seen more people, as well as tidied up the data, but also put in better systems and processes that mean more people will be able to be seen going forward. And as I said, the next stage for us is to work with our teams to make them think as creatively as possible about how they can develop more capacity within the confines of the existing resource that they have.
Okay. And Chair, if I just may, just one final question then. So will you be able to provide follow-up information outside of this meeting showing exactly how many people are now on the waiting list?
Yeah, of course, Joe.
Thank you.
I think perhaps given the importance that we placed on this is something we could pull forward in the next IPR and actually just do a quick sort of slightly more intensive analysis of it that just answers some of the obvious questions. And I know, John, you've just pointed out that you've got the waterfall diagram, but I just think that maybe we could do that. I think the other thing is that perhaps we just need to decide what is a breakthrough objective for next year. And if this is really important, then maybe it needs to be one of the breakthrough objectives. If it isn't, then that's also a decision we can make as a board. Thank you all very much, everyone. We're a little over time now, but I think that was it was important to give the IPR the amount of time it needed, and I hope that people are comfortable with that. I mean, I think, Osman, you said up front that it's not a happy position to be in, to be not effectively not meeting any of the 30 core standards. But I think we recognize the energy that is going in to actually shifting the dial on some of the really important issues that we believe are going to impact on quality, and that then some of those core standards will come into line. And clearly you have also shown us how by the end of the year, some of those will be coming through. You just put your hand up. Have I alarmed you?
Just wanted to minor correction, say we are delivering against the green ones in the pack. So of the 30 that we monitor ourselves against, we have delivered against the set that are green, which are by and large the majority of the national ones for which we are compliant.
Yes, sorry, I think it's me misspeaking, I didn't misunderstand you. I think I just misspoke. But thank you for putting me right. Thank you very much. I'm a little tired today. Can we now move to the quality report, please?
Thank you, Chair. Taken as read, and just note the inclusion of the Learning from Deaths report in Q1 and the Safe Working Hours report for Q2 that are attached to the summary. I just want to draw your attention to three things here. One is the ongoing work following the Panorama revelations. I think the Quality Committee very much welcomed the rapid review of the 11 units and the fact that there were no immediate concerns, but knowing that there's further work underway and there's going to be further reporting to Quality Committee on this. But we also said, we need a greater focus on understanding service user and patient experience, involvement, how we can really drive forward involvement of people lived experience in improving our services, understanding complaints, as well as the ongoing quality assurance work. So those were some of the things that were discussed in that context. Secondly, I just wanted to draw your attention to the Learning from Lives and Deaths for People with Learning Disability and Autism report that Vicky Baker brought to us. You know, shocking national statistics, 49% of deaths avoidable in the learning disability population compared to 22% in the general population. And whilst we recognise that SPFT is doing really good work to address these inequalities and you know, working with the ICB, it is significantly under-resourced for the challenges. And we as a committee were very supportive of, you know, further investment here. You know, an example, the STOMP program, Stopping Over Medication program for people with learning disabilities. You know, there's a lack of pharmacy support there. So that's just one example that was brought to our attention, but really supportive of the need for further investment for this team and the work that they're doing to address inequalities. And then finally, I think, you know, linking with some of the discussions earlier about quality improvement, we were really pleased to see, you know, the further progress on rolling out quality improvement work on therapeutic obs. So important that we're going to be seeing more of this coming through to Quality Committee. We're really pleased about that. And as you see from the report, we're still waiting for more work on the kind of outcomes on clinical effectiveness, and looking forward to further discussions once it comes back from the subcommittees to ourselves. And I'll stop there. Happy to take any questions.
Okay, thank you very much.
I just augment the last point, Anna, if that's okay. And just that we will be looking closely at the effectiveness agenda, and I guess expecting more progress. I mean, it's been slow. We need to get it right. Obviously, we need to select the right criteria, but there's a number of forces aligning at the moment that makes this even more important. And I think over the coming committees, I think we've all agreed to really put some energy and effort into it.
Yeah, thank you. Anything else on the Quality Committee report? And I think we covered quite a lot of quality issues as we've gone through the meeting, which is as it should be. But Mandy.
Yes, thanks, Chair. I think we have today. I suppose I just wanted to add in regarding the patient safety strategy and that ongoing work. So within this quarter, there has been a continued focus on the application of that patient safety incident response framework, and particularly in relation to the focus around commencing of the patient safety partner role. So these will be experts by experience who have first-hand involvement in patient safety incidents. The role will be to support and review incidents within the organisation alongside the teams to help apply some system-based learning. And the patient safety specialist has met with the experts by experience within the trust, carers and family members of those who've sadly experienced a serious incident. And we now have 3 patient safety partners engaged. So I just wanted to give that brief update in terms of that really important patient safety strategy. And again, quality improvement coming from, you know, from not only the teams, but families themselves as well, to support us with that.
No, that's really important. Thank you. Thank you very much, Mandy. Okay, if there's nothing else on the Quality Committee report for today, thank you to the committee. Thank you, Anna, Kevin and Mandy for those. Can I now move to finance and investment, please? Nitin.
Thanks, Chair. Hoping you can hear me.
We can hear you. We understand you're staying off camera.
Okay, perfect. I'll take the report as read. Just highlight a couple of things. The capital program year-to-date spend was about 9.9 million against a budget of 13.6. Most of that underspend is coming from the RISIS slippage. I know the team is looking at how we go about it, given that we will not be able to spend it this year, whether we lose this funding, or how do we make sure we don't lose this funding for next year and can still continue the work. Usman might have a update on that. I'm not sure if there is. Usman, let me know. And the other thing I just wanted to highlight was the month 7 deficit of 9.1 million against a planned surplus of 0.4. So 9.5 million overspend. Year to date, our sort of gross risk is now 26 million, reduced to 16 million with our cost efficiency program. Behind and still work to be done for the rest of the year to get it back to even. I will let it be at that and take up any questions.
Okay, thanks, Nitin. Usman, was there anything you wanted to add to that?
Nothing particularly that, Chair, that I wasn't going to pick up as part of just the sort of run through of the month 7 finance report.
Okay. Well, I'll just quickly check if there are any questions for Nitin on the committee report itself. It appears there aren't. Usman, do you want to go into the finance report then, please?
Thank you, Chair. So I will take the report as read, but I'll just take us through some sort of key areas. I will just say, as ever, with the finance report, it's been iterating all year, and we have iterated yet again. So there is a slightly sort of new format at the front. Feedback welcome, but we are trying to get to the point where we're sort of keeping this as clear and as concise as possible for members, but provide enough detail. So as Nitin said, year to date, month 7, we had a £9.1 million actual deficit. The causes of that deficit, so in month, the deficit increased by 1.8 million. Causes of that deficit are as they have been all year, which I'm sure is frustrating to hear, but I suppose on one hand also reassuring that there isn't anything that we hadn't known was going to happen. So the drivers of that overspend continue to be the use of the independent sector beds and the agency premiums that we're incurring as a result of the high vacancy rates that we have. The areas of spend for agency are broadly the same, although I think it is worth noting, and you will hopefully see this on sort of slide 4 of the actual finance pack, where we set out the graphs and summary positions, but our spend on medical agency is increasing. As we see sort of reductions in some other areas, in particular around our HCA, where we have some really good work has been done. I think the teams should take credit for some really, really great work around both the shift from off framework to framework, but actually just a total reduction. But it is being offset at the moment by what looks like an increasing spend on medical staffing, and that is purely down to vacancies and the difficulty in recruiting medical posts, in particular consultant posts, and sort of the agencies we're having to use and the rates that we're changing are escalating. It is a pattern that is consistent, I think it's fair to say, with other organisations. We're not unique in that, and we're seeing similar scenarios play out at some other mental health trusts. That's sort of the year to date. In month position, I think the other thing worth just highlighting is when you look at slide 5 and you see the overspend, you will see that we're actually over on income. And the reason for that is largely related to the funded element of the pay award, which in the year-to-date position is about £3 million, although there is a unfunded element of the pay award, which year-to-date is about £1.3 million. And the additional income we've received from HEE for trainees, which all sort of sit within our total operating income line. There is also a significant element of that which is driven by, and I'll come on to it in a second, around the provider collaborative funding to offset the non-pay overspends for placements. I just thought I'd highlight it, so I've had questions outside of it separately just about why are we over on our income. So hopefully that covers that. We have set out in a fair amount of detail where those overspends are coming from. I won't go through those in detail. We have been through this before in quite a lot of detail. The Finance and Investment Committee and the primary drivers of our overspend are largely the same. The one thing I do want to highlight, well, two things I should just say I would highlight. We have provided quite a lot of information around our workforce position, both in terms of inpatients and in terms of community and urgent care. And you will see there those high vacancy rates within urgent care are why that was part of our business continuity focus. That ability to make sure we have a really good out of hospital crisis offer is what will be part of the longer term transformational change around changing our model, becoming less bed-based and being able to do more in the community. So I think there's a really good link between what we're doing for business continuity now, but it also linking to where we need to get to in the future. They're not separate things. And then I suppose the last bits just to highlight from the financial management section, we are clearly overspent year to date, £9 million. We still have a break-even plan for the full year. And I think it's worth highlighting that we have identified a full year risk of circa £16 million. And we're currently in discussion with our system partners around what that means for the trust in terms of our year-end position. We're not making any decisions, but there are live and active conversations, as you would expect us to have, given what our year-to-date position looks like. In terms of the non-financial management sections of the report, Nitin's already alluded to the capital programme. I think it's worth saying against our core capital allocation, we're on track and actually likely to spend, well, we're overspending at the moment against it, and we'll manage that through slippage by year end. Against the nationally funded programme, in particular the Sussex redevelopment, we are underspending at the moment. The reasons for that sort of have been, it's a really, the timelines for that programme are really challenged. We've been working with our regional and national colleagues and partners around how we can help manage that and what options we have for trying to accelerate some areas of spend so that we can make use of all of that funding. But clearly it will be a risk as we go into the fourth quarter, and we will keep the board updated and keep the finance through the Finance and Investment Committee. And you'll also note on there that the cash flow summary, cash position at October does look is off plan. Partly that is driven by the year-to-date deficit, but that's also partly driven by we have not yet received significant amounts of funding that are forecast to arrive in December, later this month, that we're confident will arrive. So it's just to highlight that I think there's a timing difference and not anything else to be concerned of at this stage. And Chair, I'll stop there and have to take questions.
Okay. Thank you very much. Are there any questions for Usman, please? No. Usman, am I right? I mean, you've obviously just presented a very complex and adaptive system there. But I suppose I still feel that agency spend is one of the key drivers of the run rate. It's a key driver of quality and it's a key driver of the run rate. And I just wonder whether we feel we've really got the traction we need on agency.
I think so. You're absolutely right. Agency spend is probably the biggest driver of our year-to-date position and our sort of risk position. So £10 million year-to-date overspend against for that sort of agency premium element. I think we have made a lot of significant progress. I think the groups that have been set up in the sort of, well, that were already existing, but I think have been energized over the last few months, in particular the temporary restaffing group, are having traction. I think the reality is, though, this is going to be a piece of work that goes into next year and has to be focused around looking at where do we put a limited resource. And I think workforce, we potentially have to stop thinking about, workforce as we're growing a service and therefore we will just be able to go out and get people. I think we're going to have sort of much more focused conversations around where do we put a really limited resource as we move into next year if we're going to drive down that agency spend. But that will clearly involve sets of decisions for us to make. Yeah. But in the course of this year and what we're doing towards the end of the year, I mean, we spent £3.4 million on agency in August. That's been reduced down to £3.1 million. Last month, 3.2 million this month, and on November I won't second guess the position, but I'm confident that we'll continue to see that downward trend. So I think the work we're doing in the short term around the things that we can control in terms of our framework, the rates, the approvals process is all happening. There are more fundamental questions for us in the context of a sort of 30% vacancy rate in some of our teams.
And it speaks to what John was saying around medically fit to discharge. There's something about understanding not just where the vacancy rates are, but where some of the potential skills are in other organisations. And is there a workforce that we can develop in community and voluntary organisations, as well as pulling towards ourselves? There's something about just making sure at the right point that we understand that, but I don't want to disrupt the work that's going on at the moment. So I'm going to go to Claire next, if that's okay, Nitin, and then I'll go to you, Nitin, and then to Joe, then to Kevin.
Thank you. I just wanted
Claire.
to come in on the work. Thank you, Chair. I just wanted to come in on the work that we're doing on the medical agency, and just to, I guess, to talk through a bit about the assurance processes that we have on moving and reducing the amount of medical agency as much as we are, obviously mindful of the vacancy rate that we do have, both in terms of the spend, the framework, but also the work that our medical leaders are doing on supporting our agency workforce. I think it's fair to say that the quality of short-term staff coming into our posts is varied, but we are providing enhanced supervision where we are employing agency, particularly for shorter periods of time, aware that settling in and getting to know process is difficult. And so it's something that we are very sighted on and giving support.
Okay, thank you. That's good to know. Nitin.
Thanks, Chair. Yeah, just wanted to come back to the point of agency. When we had this year's budget, we had a savings target of 3 million in staffing. And obviously, instead of saving, we have overspent, or we've gone over what we said we would. And you're absolutely right, that's leading to an imbalance in the budget. But as Usman said, we are seeing small hints of improvement, and that's really important. And I have to commend Usman and the team, because I feel like the Finance and Investment Committee pack is now getting a lot more easier to understand and discuss some of these points. So as we come into next year's budget, it'll be really good to have a discussion, because to make any dent in savings, we will have to tackle agency spend, and it'll be really good to understand what those initiatives actually will be for next year. Yeah. So they have the confidence that we will actually hit them.
I think that's good to know. Joe.
Thank you. Claire, this is linked to the point that you were making about the use of medical agency doctors. I seem to think that this is a newish trend in terms of the increase in the number of medical consultants and others. Is that the case?
I think there's a small increase over the last 2 years, but it's over that kind of length of time. It's not exceptionally new, that we've always used what I would see as quite a rate of agency, particularly between gaps. There's always gaps as people leave.
Yeah. But until recently, it has been a relatively small compared with nurses and HCAs. And my question, and this is more curiosity than anything else, is there any sense or any feeling in terms of is this trend likely to be one that's going to become a bigger one? And if so, what, if anything, are we able to do about it? And I'm not expecting any instant answers, but it's the alarm bells in terms of just picking it up now and addressing it.
I'm happy to come back straight away.
Yeah.
So we have a large workforce plan that's led by each clinical director and each of the CDSs to look at recruitment, retention, and sort of ensuring that we have minimal agency use, but we're maintaining safe services. We have in place a fortnightly agency review meeting where we review each post with medical staffing to ensure that it continues to be needed and that we have the minimal amount of medical input that, as I say, ensures a safe service. I think in terms of trends going forward, I think nationally there are certain specialties within mental health where it is becoming more of a problem. Old age psychiatry, CAM psychiatry in particular, recruitment is extremely difficult. So I think we are also looking at our pipeline of training numbers and trainees who we have coming through our service. We've increased the recruitment and retention payment for recruiting new consultants to be attractive and on a par with some of the other mental health trusts and what they're providing. So there's quite a multifactorial process looking at how do we make Sussex Partnership attractive to consultants to come and work for us. But I think that the reality is that there are not enough psychiatrists for the posts. And the increase in agency is just in consultant psychiatry. We have agency use for some out of hours shifts for junior doctors, but actually that's been mitigated by an increase in training numbers. And so actually, if you look at the CMO budget is in deficit because actually we're managing that extremely well at the moment, and we're coping with out of area agency use with much less use out of hours. It's the substantive vacancies of consultants that we've got.
Thank you.
Thank you, Claire. That's really helpful. Kevin, and then I'm going to wrap this up. You might be on mute. I'm not sure.
Oh no, sorry about that. That's quite retro, isn't it? Yeah, those of us on the consultant panel tomorrow will not be in any way influenced by the finance. Say that at the outset. I guess my point was that the nature of these structural deficits, we know, are long-term, and that the turnaround will be a long-term turnaround. I think we need to all kind of hold our nerve on this, that it is the things we're talking about, the bigger things we're talking about, the community transformation plans, the new models, the devolving of power, and the hopefully subcontracting of some parts of our services into a more kind of community-based model. I think that will ultimately turn around these things, and a comprehensive workforce development strategy going forward. So we are working on this year, but we need to have eyes on 24, 25, 26, because I think that's where the strategic remedy will occur.
All right, thank you. Well, that saves me doing a summary. Thank you very much. Let's move now to the audit committee report, please.
Thank you, Chair, and I'll keep it brief. Take the report as read. The one item that we did want to escalate to the board was in respect of 6 of the priority policies which were out of date or then needed to be updated. But in fact, I understand from Dom that on a meeting that took place on Monday at the policy forum, all of those 6 outstanding policies have in fact been updated. And if they haven't, it will have been completed by the end of this month. So thank you.
Good, that's wonderful. Thank you. Are there any questions for the chair of the audit committee? A thumbs up from the company secretary. That's a rare event.
I don't think he meant it for me. Thanks if you did, Dom.
Okay, thank you. Oh, sorry, just a very special moment I was having there. Can I now move to the board assurance framework? I think through the meeting today, we just need to reflect on the meeting and what significant risks we identified in the meeting, and then satisfy ourselves that they are meaningfully captured in the words in the board assurance framework. And I suppose there's something in about the community, the risk we're carrying in the community and the need for community transformation, and the fact that we know that there's a workforce element to that, and there's a flow element. I mean, dealing with the long lengths of stay and medically fit to discharge. I'm not sure that's quite captured in. If we think those are the really 2 significant drivers, I'm not sure if that's quite captured in the BAF, but I'm checking with board members. Jane, what would your view be? Sorry,
I couldn't find the mute button then. I thought it was on Teams, not Zoom. I think you're right. I think it's refining what's there. So I think there's something for how we so the example I give is we've got a very, very generic sort of recruitment and retention, how we fine tune that so we know specifically what we're talking about. And I think the general areas are right. It's about how we fine tune it and nuance it, that it's very specific to this organisation and the current risks.
Because it seems to me we've got to go back to being a little bit braver about how we articulate the risk and then how we're going to focus on it. And there is something, I think, perhaps just about breaking some of these down. So if it's about the risk to recruitment in crisis teams, well, let's say that and then have that as the thing that we're driving. I mean, that may not be quite the right example, but I think maybe that would be one. There's something for me around complaints and that how that relates to the community survey. There's something about how are we capturing patient experience and responding to patients, I think, that came up in this meeting. And clearly there are the pockets where we've got variation or where we've got clinical risk sitting hotter in some places than others. And I wonder if we could just ask the executive team to just go away and have a look at that. Are there any others that people can think of through the meeting? Dom.
Peter, I was just going to say, looking at the detail, I agree completely. And I think actually we can bring out perhaps both in the description of the risks, but also in the detail which sits beneath them in terms of controls, gaps in assurance, some of those issues that we've talked about in detail.
I certainly don't. I think it's working well. I think it's just making sure that in each board meeting we just stop and think, hang on, what was the real risk today that we were talking about? I've got Joe and Dan. You may be on mute as well, Joe. I'm not sure.
To myself, that's always a good sign. Yeah, my point is in relation to admin staff and that part of the workforce, and having some clarity again around the strengths of those teams and whether we have any exposure on that front.
Yeah,
I don't have a strong sense of how we're tracking that and where we are. I'm just thinking of a discussion that we had earlier today, Kevin, with a colleague, where in fact there are some particular staffing issues and they are admin staff, and it's having a real impact on the ability of that area to deliver. So could we add that to the list in terms of exploring whether there is something there that needs to be tracked? Does that make sense, Claire Webster?
It does, thank you. I mean, I guess we'd have to, I know we talked about this being very generic in its approach, but I guess that the fact is the current situation means there are more areas of shortages than where we're overwhelmed. So it's difficult.
Yeah, and I think, but the important point was, as we picked up this morning, was the impact on that particular area, on that team to deliver. Because they were clearly having problems in terms of being able to meet the delivery deadlines.
Yeah.
Thank you.
It might just be adjusting risk 3, mightn't it, to reflect that?
Yes, it might. Yes. Dan.
You touched on this, Jed. There's something for me about refreshing and revitalising the whole theme of patient experience and engagement to reflect the discussions that we've been having as a board over the last few months, particularly with respect to the work on the breakthrough objectives for 23-24.
Yeah, thank you. Dom.
Thanks, Chair. And Joe's point is a good one, where under the gaps in controls in risk number 3, we can refer specifically to career pathways and professional development for admin staff and just be more specific about some of those issues.
And I think that's where I'd like to get to. This feels more dynamic and we're adjusting it to meet the needs. Okay, I suggest that if we could ask the executive team to go away and have a look at that for us, bring that back to next board. We'll have the breakthrough objectives coming through to that board, and then we can have, I think, at a board development session, just a discussion then about, well, how does the BAF need to adapt in the light of the new breakthrough objectives for 23-24. A phrase I haven't quite got used to saying yet. It feels like such a long way away. However, I think it's okay. So everything on the board assurance framework for today. Lovely. Thank you very much. Dom, sealed documents report.
Thank you, Chair. I think we have 8 minutes now, and sadly, this may be my ultimate 6-monthly presentation of the sealed documents report, and which the board has asked kindly to note.
Is the board happy to note the sealed documents report? Fantastic. Thank you very much. Can you thank everyone who contributed to the production of that, please? So I have 2 items of any other business. Are there any other items of business before I move to those? So can I just firstly, on behalf of the board, thank Mandy for your role as the interim chief nurse. I think real focus on quality improvement and making quality improvement move from the conceptual to the reality. And I think actually linking quality improvement to some of the real challenges we're facing as an organization. And I know you've done that with other colleagues, but I think that's really something that's shone through, that real commitment to quality and to patient experience, I think is something else I'd pick up. You've been a delightful colleague, and thank you so much for what you've done for us. And we wish you well, and we'll have other opportunities, I know, to speak to you, not leaving the organization, so we'll still be in touch with you. But I just wanted to acknowledge today the role you've played as chief nurse, and it's been quite a bouncy year. So,
Thank you, Peter. I really appreciate it, and appreciate everybody's support here with carrying out my responsibilities across that portfolio. I've thoroughly enjoyed it. Thank you, and a huge experience for me. Thank you.
Good. Well, I'm glad that's how you feel. And then not last but not least, to Martin as vice chair. This is your last board as vice chair and senior independent director, and we're going to have to just separate those roles out. We can't find someone who can combine those roles in the future. But if I could just thank you, you've been a very good vice chair for me. You did your 6 years, and then we asked you to do an additional year, and you did that very happily, and we were really delighted that you were able to do that for us. You've introduced me to sporting metaphors in a way that I never experienced before, and I feel richer as a result of that. But to be serious, I mean, I think you have given just the right amount of constructive challenge to me as chair, and I've always felt supported. But I know you've also been said when you thought there was a different way of doing things, and I've really appreciated that. And I know that your experience and expertise has been really appreciated in terms of emergency planning. I think that your contribution to GOLD through the pandemic, again, your experience of how you deal with those sorts of situations was really valuable to the organization. And I think there's a lot of work that perhaps people don't see that you do in terms of providing an independent view to some of the complaints and grievances that we get in the organization. And your role as senior independent director is obviously not necessarily a very public role, but I know it's one you take very seriously. And I know that anyone who then came and looked at that would see that you had brought an independence of perspective on situations that obviously can be very long-standing and very frustrating, but we still need to make sure we stand back and question ourselves and check that we're responding to them properly. So I did just want to take this opportunity in public to thank you at the end of this board meeting, but I know there'll be other opportunities as well. Thank you.
Peter, if I may, that's really kind of you. And I think when you look around the screen in particular and see that I'm pretty sure none of the faces were present at my first meeting, then you know it's probably time to go on the one hand. But on the other hand, frankly, especially John, with your presentation today and the responses to it, I also feel that with the faces that I'm now looking at, you know, the trust is in great hands. It's had its ups and downs, but has continued moving forward throughout those ups and downs. And I know that will continue. So I wish you all the very best in the challenges to come. Thank you.
Thank you. On that note, I'll draw the meeting to a close. The date of the next meeting is the 1st of February, and look forward to seeing everyone shortly. Thank you very much indeed. See you soon.
Peter, can I just remind everybody that it's a separate link? So you need to join the meeting on a separate link.
You can do that. You've done it.
Thank you.